Hello, my lovelies. Welcome to my channel. This is Dr. Emmanuel, and I want us to look at a PLAB2 approach to a station on personal problem or erectile dysfunction. This is Emmanuel Academy. So this station goes as follows. So you are the foundation year 2 doctor in GP surgery. Andrew Moore, a 54-year-old man, has come to your clinic. He has a personal problem, speak with him and address his concerns. So the presenting complaint is problems with erection, okay? It's just a hint. So he's 54 years old. His name is Andrew Moore. He might tell you he wants to be called Andy. And he's come with personal problems. Just a minute. So how do you prepare, while you're still outside the room before the bell goes? How do you prepare? What I usually advise is remind yourself of the patient's name. So who am I seeing here? This is Andrew Moore. He's 54 years old. And what has he come, to clinic with today? He's come with personal problem. So when you see presenting complaints as personal problem, or when you've been told the patient is coming with something personal, your mind usually goes into things like, things that are probably very personal, sexually related, problems with their genitals, their private parts, maybe, vaginal prolapse in a female, for instance, abnormal vaginal discharge, things that they don't feel very confident, telling the receptionists. And they just tell them, book me in, I want to see a GP. And the receptionist will ask them, why have you come to them? They'll say, it's something personal. Okay, they don't want to divulge. They don't feel confident, or comfortable divulging that information to the receptionist. Okay, so he's coming with personal problem. He's 54 years old, and when you greet him, introduce yourself to him, establish your rapport and ask him why he's come there. He'll tell you something personal, or he might tell you he has sexual problems, and you have to initiate your consultation from there. So while you're outside, you ask yourself, what could this personal problem be? It could be something related to his sexuality, it could be something related to his genitals, it could be a hernia, it could be, a hemorrhoid, it could be visual and anal, it could be anything, It could also be a safeguarding problem. Okay, it could be that maybe he's not safe. He's in a relationship. He's a victim of domestic abuse. And he just doesn't want to tell the receptionist that, but he's going to open up to you. So keep an open mind. It could be anything. But in this particular station is erectile dysfunction. So just a reminder, in your PLAB2 examination, you're being assessed on 3 domains or 3 competencies, and those are communication or consultation skills, which is otherwise called your interpersonal skills, how you communicate with these patients, how you establish rapport, how you maintain the rapport throughout your consultation, how you're checking, the patient is understanding what you're saying, how you're sharing the decisions, when you get to your management, you're telling the patient things that you advise or things you recommend, and you're checking what they think about it. Are you happy with this? Does this make sense? Is this something you want to follow through with? Making sure that it's not just you who is, all in charge of the consultation, but you're having a shared decision making with the patient who owns the body. You'll be assessed on your data gathering and interpretation skills, how well you're able to take a focused history, do your focused examination, request, focused, relevant investigations, and interpret those results, and how those results help you arrive at your diagnosis. And then you will be assessed also on your management or decision-making skills, okay? The kind of management, treatments, advice, or modalities you initiate. So those are the 3 domains or competencies you'll be assessed on in the exam. So when you walk in, of course, you have to greet the examiner, give the examiner your examination number, examiner will ask you if you're ready. You say yes. He'll point at the patient and ask you to start. You introduce yourself to the patient. Hello, I'm Dr. Emmanuel. I'm one of the GPs in practice today. I'm one of the junior doctors I'm one of the doctors. There's no need to put junior. I'm one of the doctors in the GP surgery today, in the practice today. Pleased to meet you. Are you Andrew Moore? He will say yes. And is it okay? How do you want me to call you? If I say, doctor, call me Andy or call me Andrew, then you say, what brings you in today? Or you say, I understand you've come in with something a bit personal, or a bit private or personal. Is that all right? Is that okay? Do you want to tell me more about this? Usually, you're his doctor. He'll open up. He'll tell you, oh, I'm having problems with my sex, or I'm having sexual problems, or having problems with my erection, depending on how he puts it. Okay, you have to empathize. Oh, I'm really sorry to hear about that. Do you mind telling me exactly or a little bit more about this? You might say, doctor, what do you mean? Or he might open up and tell you, okay, yes, that over the last few months, I've noticed that my erection gets weak, or I don't have erections when I, try to make love to my partner. My private part just doesn't. Or he might say my willy. So don't be confused if you hear the word willy. He might use the slang willy, which means the penis. Might tell you, my willy just doesn't work, or it gets wrecked, and within the next few minutes, it all goes flat. So depending on how he paints the picture of the erectile dysfunction, it might be a complete loss of erection. It might be, a very short, that's not a well-sustained, penile erection. So he might tell you things like that, and you have to show empathy, both in your facial expression, the tone of your voice, the way you're sat, you have to say, oh yeah, I understand this could be really distressing. I can only imagine this could be really distressing. And for how long have you having to tell you, oh, you had this for a couple of months. How long roughly would you say? I tell you over the last 5 months. And then you have to be asking yourself, why now? If he's had this over the last 5 months, why is he coming now? Have things got worse? So you say, okay, since it started, have you noticed that it's got worse over time? Might tell you yes. So what are you particularly worried about? You say, oh yeah, I'm in a new relationship. I've not been sexual with my new partner, and I'm really scared that if my new partner finds out that I've got these problems with my erection, it will cause a lot of problems in our relationship. Okay. So check what he's most worried about and check his ideas. What do you think may have caused this problem with your erection? What do you think? What are your thoughts on this? Okay, what are your thoughts on this? What do you think may have led to this? He might tell you, doctor, I'm suspecting because I smoke or because I drink, or I really don't have any idea what could have caused this. So what are your expectations? What were you hoping? What are you hoping to get out of this consultation, or in what ways were you thinking, hoping that we'll be able to help today? So explore his ideas, his concerns, and expectations. It's good to explore those things early enough. It gives the patient the impression that you care about how they feel and what they really want from that consultation. And it also helps you understand how you're going to tailor your management towards meeting these, ideas, concerns, and expectations. Okay, either allaying his anxiety or actually following through with his expectations, or giving him reasons why you wouldn't follow through with those expectations. Okay, yeah. So you explore his eyes. You need to do it. Take a sexual history. Ask about. He might have told you that he already has a new partner, or he's been having. He's had a long-term partner, and this problem has over time developed. So ask him if he feels anxious, because anxiety and even depression can cause erectile dysfunction. I think 10% of cases of erectile dysfunction are psychological. In young people, this patient is 54, so he's not very young, but in very young patients, like patients in their 20s and 30s having erectile dysfunction, you'll be thinking more of psychological causes. When a patient in his 50s, 60s, you're thinking more of, organic. It could also be psychological, but it could also be organic, okay? Because at that age, they could have cardiovascular problems. So check, explore if he's feeling anxious, if he's scared, if he's worried that he might not perform well with his new partner sexually. Find out if he's had any previous sexual partners, how well, if he experienced similar problems with his erection, in his previous relationships. Do a medical history, past medical history check. Ask him, have you got any medical history, like high blood pressure, diabetes? He might tell you, oh, yes, I have diabetes, I'm diabetic. Explore for how long have you been diabetic? Are you on any medications? How well has your diabetes, been well controlled? How well controlled has your diabetes been? Now, the reason you're asking all this is, as we said, erectile dysfunction could be a marker of cardiovascular disease. You need to also ask if he's had any pelvic surgeries, okay? Has he had any pelvic surgeries, any surgeries on his prostate, any surgeries on his testicles, his groin, the inguinal region? You need to explore all of these, okay? Because these could also contribute to, damaging the nevi erygentis, okay? Or the pelvic splanchnic nerves that subserve penile erection. You want to take a drug history or medication history. Is he on SSRIs, antidepressants like sertraline, fluoxetine? Is he on thiazide diuretics? Is he on any medications? You're thinking medications that could cause erectile dysfunction as a side effect, okay? Is he on prostate medications like finasteride, or anti-androgens for treating prostate cancer, things like bicalutamide and all of that. So you need to explore his medication history. And you also want to ask him what he's tried. Have you tried anything? Are there things you've tried so far to help with these problems with your erection? Have you taken any medications to help? He might tell you he's bought the blue pill over the counter, which is sildenafil, Viagra. Or he's tried Viagra over the counter and it's probably not worked. He might tell you he's not tried anything. Yeah, it depends. So throughout that consultation, you have to empathize. You have to show that you can imagine the distress this problem is causing him, okay, both personally and in his relationship, okay, his sexual life. You have to empathize with him. You have to tell him you need to offer to examine him. Oh yeah, I understand. This is really a distress to you. Is it okay if I, examine you, check your blood pressure, your heart rates, okay, feel your pulses. So usually when you say this, the examiner will give you the findings, might tell you the blood pressure is 160/84 or something like that. Heart rate is normal. In the history, you might establish that the patient is hypertensive, has atrial fibrillation, has some cardiovascular issues. It's probably type 2 diabetic on, metformin and some other medications, examine the chest, listen to his lungs, listen to his heart sounds for murmurs, for abnormal heart sounds, examine his abdomen. You want to check if he's got, a pulsatile expansile, mass like a like a AAA, abdominal aortic aneurysm, okay? Of course, you want to examine his groin, so you tell him you like to do a groin examination. Would he like a chaperone to be in the room? Okay, if you would like a chaperone, of course, the examiner might give you the findings and tell you that's okay. Genital examination, testicular examination is fine. Tell him you also like to do a PR, okay? Explain that this examination could feel uncomfortable. That's what it entails is I'll put one of my fingers through your back passage to have a feel of your prostate, okay, and to feel for any lumps or bumps. Okay, is this something you'll be happy to have? You say, oh yeah, I think if it's something that needs to be done, it needs to be done. The examiner might tell you, oh, the rectal examination is fine. Say, okay, fine, thank you. You discuss examinations with him. You say, I've heard the things you've said, and you've told me you have even over the last 5 months, you've been having troubles with your erection, and you're really worried that it might affect your new relationship. You said you're diabetic, you're type 2, you're type 2 diabetic, you're hypertensive, you're on so medications. you're on metformin, you're on this, you're on that. And on examining you, I can't find anything abnormal on examination. Okay, your heart sounds fine, heart sounds, are normal. I felt your pulses and they feel normal, and those are reassuring. So you need to tell him those are reassuring. It's good news. You tell him that at this point in time, I really can't say why you're having these problems with your erection, but there are several things that could cause it. It could be that maybe you're feeling anxious, performance anxiety, or that's, it could also be a complication of some of your medical problem, medical conditions like your hypertension and your type 2 diabetes. Do you understand? Does this make sense? You say yes. He might say, "Oh, doctor," he might give you that knowledge. "Oh, doctor, so what do we need to do?" Or if he doesn't say that, you need to now say, "Okay, so what we can do is we can try some medications." You said you've tried the blue pill over the counter. We could try prescribing from the clinic, just so we are sure that it's exactly the right dose you're having. So you could still prescribe sildenafil, but this time from the clinic. Or you could tell him, since you've tried this blue pill, we could try some other medications that could help. So which is tadalafil. So you can prescribe him some tadalafil to use about 30 minutes to 1 hour before any sexual activity. Okay, and then you could, his medication history, you need to make sure he's not on nitrates. Okay, like isosapine mononitrates or dinitrates, and he's not using the GTN spray. Okay, he's having anginas and all of that. So you need to tell him all of those, and you have to tell him that you need to do you need to do some investigations, some blood tests. You need to do some full blood counts, kidney function, thyroid function, liver function tests. And you also need to do some hormonal tests like check his testosterone level and check his prolactin level. Okay, you want to check if there's a hormonal endocrine cause to his erectile dysfunction. You also want to check his HbA1c. If he's not type 2 diabetic already, you want to check if he's not known to be diabetic, you want to check if he is diabetic, because ED can be a side effect or complication of diabetes. You want to check his kidney function. It can also be a complication of renal impairment. You want to check his thyroid function, same thing. And then if it's endocrine, you want to check his testosterone level and his prolactin levels. You also want to do an ECG as part of your cardiovascular evaluation. So you want to also do an ECG. So after doing all of this, obviously you will need to arrange a follow-up visit. You tell him that, "Andrew, try this medication. Let's have a look at these blood results. And when I've had a look at the results, I'll book a follow-up appointment, and then we'll have a chat. And I also get the opportunity to review if these medications have helped, how things have been over the last, in the next couple of days. Does that make sense? Is there any other thing you were hoping, we'll do for you today?" So you need to check, is there any other thing you were hoping? Usually in the exam, the patient will say no. Okay, no. Oh, thank you very much, doctor. You've been so kind. But in real life, obviously, the patient might come up with something else. Say, "Well, doctor, yeah, I've also noticed there's a mole on my back." He might want to tell you something else in real life, but in the exam, usually they wouldn't do that. Okay, they will keep it straight to the point, succinct, just so you're able to manage everything within 8 minutes. So we've come to the end of this station on erectile dysfunction or personal problem and how you can approach it. So you have to pay attention, know that you're in a GP surgery and what you're doing. So you're not managing this station like someone who is in a urology clinic. You can see that you're not doing it like someone in a urology clinic. Even if you were in a urology clinic, you will still start with the basics of taking a focused history, doing a focused examination and requesting, basic investigations first, so you request these blood investigations first. Then if things don't work out, you tell him that if the blood, if your follow-up visits or assessments, if the tadalafil or sildenafil has not worked, and the blood investigations are normal, so you can't find an identifiable cause of his erectile dysfunction, that you might need to request further investigations like testicular ultrasound, or you just refer to a non-urgent referral to the urology team. Okay, the urology team may then request the ultrasound, testicular ultrasound, and all of that, and probably do some further investigations and further treatments, modalities. So you're in the GP surgery. Usually the examiner just wants you to initiate the appropriate management, which is giving him the option of trying this medication 30 minutes to 1 hour before any sexual activity, you know, um, giving him the option of you taking these blood samples and sending them off and reviewing the results in the next couple of days, and then booking a follow-up visit or consultation with him to discuss the results, to check how things have been, if he's noticed any improvements with this medication, and then to discuss further plans if you need to refer him for further investigations or, a non-urgent referral to the urology clinic. So you have to understand how the system works, how the system is, divided into the primary care and secondary care. So having a good knowledge of that will help you walk your way through, managing any case that comes to you in the PLAB2 examination successfully. So thanks for your audience. I really appreciate that. Thank you very much.